Hello, welcome to Pediatric Pulse. In today's video, we are diving into an important topic on emergency drugs and their pediatric doses. Whether you are a healthcare professional, a student, or a parent, understanding the correct dosages for children in emergency situations is vital. Stay tuned as we break down each drug with its uses and the precise dosages needed to effectively and safely treat pediatric emergencies. The first drug is adrenaline. Here are some of its uses and doses. In cardiorespiratory arrest, we administer at a dose of 10 micrograms per kg in pediatrics. And for bradycardia of below 60 beats per minute despite adequate oxygenation and atropine administration, we administer at a dose of 10 micrograms per kg. It is also used as a first-line inotrope as an infusion centrally and peripherally in fluid-resistant septic shock at a dose of 0.05 to 0.3 micrograms per kg per minute. Adrenaline is also used in anaphylaxis. Remember, its dose in anaphylaxis is age-based. For the doses, kindly refer to our video on administration of adrenaline in anaphylaxis. Another emergency drug is amiodarone. We use it in refractory ventricular fibrillation or in pulseless ventricular tachycardia. These are the two shockable rhythms that we have. We administer amiodarone at a dose of 5 milligrams per kg, and we administer it before the third shock and after the fifth shock during synchronized cardioversion. In this slide, we have adenosine. We use it in management of supraventricular tachycardia. In neonates, we administer at a dose of 150 micrograms per kg, then increase the dose in steps of 50 to 100 micrograms per kg every 1 to 2 minutes. The maximum single dose is 300 micrograms per kg. In this slide, we continue with adenosine. For a child between 1 to 11 months, we administer adenosine at a dose of 100 micrograms per kg. Then you increase the dose in steps of 50 to 100 micrograms per kg every 1 to 2 minutes. The maximum single dose is 500 micrograms per kg for the child between 1 to 11 months. For a child between 1 to 11 years, start with a dose of 100 micrograms per kg, then increase in steps of 50 to 100 micrograms per kg every 1 to 2 minutes for adenosine. The maximum dose of adenosine, single dose, for a child between 1 to 11 years is 500 micrograms per kg. Still with adenosine, for a child between 12 to 17 years, start with 3 milligrams, followed by 6 milligrams after every 1 to 2 minutes if required. Then followed by 12 milligrams after every 1 to 2 minutes if necessary. For atropine, we use it in bradycardia resulting from vagal stimulation. Up to the age of 11 years, we administer 20 micrograms per kg. And for a child between 12 to 17 years, we administer 300 to 600 micrograms per kg. Remember, larger doses may be used in case of emergencies. In this slide, we have sodium bicarbonate. We administer at a dose of 1 millimole per kg, which is also equal to 1 ml per kg of 8.4% of sodium bicarbonate solution. In newborns and infants less than 3 months, the weaker the concentration, for example, 4.2% solution should be used. This is to limit the osmotic load. Remember, the decision of further doses should be based on blood gas analysis. In this slide, we have calcium. It is indicated in treatment of documented hypocalcemia, hyperkalemia, hypermagnesemia, and overdose of calcium channel blockers. The dose for pediatric is 0.2 ml per kg at a maximum dose of 10 ml of 10% calcium chloride and 0.5 ml per kg at a maximum dose of 20 ml of 10% calcium gluconate. Here we have glucose. It is indicated for hypoglycemia. For pediatrics, we administer 2 ml per kg of 10% glucose solution. And for newborns, we administer 2.5 ml per kg of 10% glucose solution. Here we have naloxone. It is used to treat symptomatic opiate poisoning. We administer at a dose of 100 micrograms per kg in children below 5 years and 2 milligrams in those above 5 years. It can be administered IV, IO, or even IM. If necessary, it can be repeated every 3 minutes. The infusion dose is 10 to 160 micrograms per kg per hour. Here we have dopamine. We use it for inotropic support. The dose is 5 to 10 micrograms per kg per minute for beta adrenergic agonist effects and above 10 micrograms per kg per minute for alpha agonist effects. For ketamine, we use it as a sedative, as an analgesic, and even as an anesthetic agent. The dose for pediatrics is 1 to 2 milligrams per kg. It can be administered IV, IM, or even intranasal. In this slide, we have lidocaine, also known as lignocaine. We use it as an anesthetic agent. It is a class 1B antiarrhythmic. The loading dose is 1 milligram per kg at a maximum dose of 100 milligrams, followed by an infusion of 20 to 50 micrograms per kg per minute. Here we have furosemide, also known as Lasix. It is a loop diuretic. The dose for pediatrics is 1 to 2 milligrams per kg. It can be administered IV or IM. In this slide, we have Lorazepam, which is a first-line agent anti-seizure in status epilepticus. It gives sedative effects and amnesic effects. The dose for pediatrics is 0.1 milligrams per kg and the maximum dose is 4 milligrams. Here we have levetiracetam, which is a second-line antiepileptic in management of status epilepticus. The dose is 40 milligrams per kg and the maximum dose is 2.5 grams. It is administered over 5 minutes. Here we have Milrinone. Milrinone is a phosphodiesterase 3 inhibitor. Its indication include low cardiac output, septic shock which is off-label use, and the loading dose of Milrinone is 50 micrograms per kg as a bolus given over 10 to 60 minutes in children. And the maintenance dose is 0.25 to 0.75 micrograms per kg per minute. In this slide, we have noradrenaline. Noradrenaline has alpha-1 adrenergic agonist effects. Its uses include shock with hypotension, cardiogenic shock, septic shock, and the IV infusion is at a dose of 0.05 to 0.1 micrograms per kg per minute. And the maximum dose is 2 micrograms per kg per minute. In this slide, we have phenobarbital. Phenobarbital is also an anti-seizure. The dose is 50 to 20 micrograms per kg in children, and the maximum dose is 1 gram. Dose may be repeated 10 minutes after the loading dose. In this slide, we have phenytoin, which is also an anti-seizure. The dose in pediatrics is 20 milligrams per kg, administered slowly intravenously over 20 minutes. In this slide, we have magnesium. It is used to correct documented hypomagnesemia, and it is also used in acute asthma and also in polymorphic ventricular tachycardia with Torsades de Poix at a dose of 25 to 50 milligrams per kg of magnesium sulfate 10%, which is also equal to 0.25 to 0.5 mils per kg of 10% of magnesium sulfate solution. The maximum dose is 2 grams. It is also administered over 10 to 15 minutes. Here we have salbutamol. Salbutamol has beta-2 agonist effects in patients with asthma. For nebulization, we administer a dose of 2.5 to 5 milligrams of inhalation nebulizer solution every 20 to 30 minutes when necessary. It is used for moderate, severe, and life-threatening asthma. As an inhalation aerosol, we administer 2 to 10 puffs, repeated every 10 to 20 minutes or when required. It is used for moderate and severe acute asthma. As an IV infusion, we administer at a dose of 1 to 2 micrograms per kg per minute. And as an injection, we administer 5 micrograms per kg over 5 minutes for children between 1 to 23 months. And for a child between 2 to 17 years, we administer at a dose of 15 micrograms per kg at a maximum dose of 250 micrograms per dose to be administered over 5 minutes. For salbutamol, it is also used in the management of severe hyperkalemia. For IV injection, for neonate and the child, we administer 4 micrograms per kg administered over 5 minutes and repeated when necessary. For inhalation of nebulized solution of salbutamol, for neonates and the child, we administer 2.5 to 5 milligrams and the dose is repeated when necessary. Remember, IV injection route is preferred over inhalation of nebulized solution. Thank you for watching. See you in the next video.